Before we break for lunch, and that's on patient engagement within PCORnet. And I'd like to ask Bray, Sue, and Sean Tunis to come on up. While they're coming up, I want to highlight again how important patient engagement, patient leadership, other steps will be in the success of PCORnet. We're also going to hear about these topics again. We discussed some of them yesterday, but more is coming. Bray Patrick Lake and Sean Tunis were with us yesterday too, and they're going to build on some of the comments they made yesterday. Also joining us on this panel is Sue Sheridan, the Director of Patient Engagement at PCORI, who will talk about about PCORI's overall engagement strategy for reaching patient advocates across the nation to help make sure there is broad-based input into the development and execution of PCORI research. So just give one more second while we get everybody mic'd up.
What?
Are you going to go up or stay here?
Oh, do you want me to go first?
Yeah, and for those of you at the front, I understand we have a little bit of a logistical issue right here. I think after everything else we've been through the last couple of days, I think we will be able to deal with this one if just those of you who are in front don't mind moving a little bit. We've had snow and cold and wind, and now we'll add a little bit of rain to that. Always something. But Bray, I hope this won't distract you. I'd like to turn to you now for some opening comments for this panel.
So we're actually going to shake up the order.
Okay, great. Shake up the order. Excellent.
Great. Good morning. I've been bursting at the seams to open my mouth, but and I had a whole list of comments that I wanted to make yesterday about patient engagement, but all of you put it on the table, and so that was so refreshing to hear such an energized, such informed, such a visionary group. Joe has referenced, at least internally at PCORI, that patient engagement is the special sauce of PCORI. And I'm seeing that this is evolving in this group, the special sauce, and I might even refer to it as the soul of the PCORnet. And looking at the opportunity that we have at our fingertips right now, and recognizing that you have the opportunity to create a national model is absolutely thrilling to me. And something that, I wrote nice 2 pages of notes, and then yesterday it turned into 6 pages of notes, and now it's 6 pages of notes with red marker all over that, because you've got wonderful ideas. And something that I had to personally reflect on this is 15 years ago, I took an envelope about 1.5 inches tall in a Federal Express envelope, and I mailed that to 4 researchers at 4 universities in 4 states with data about my son who has a rare disorder. And at that same time, 7 other mothers were doing the same thing with the same data on their child with the same rare disorder to the same researchers. And we agreed then that we thought it was important to share all this data. And we didn't know back then, honestly, what we're doing. Listening to Devin this morning, we didn't think about privacy. We did think about privacy. We thought about some of these issues about confidentiality, but what we saw was opportunity and hope. We talked a lot about this yesterday. So we FedExed off this information, and long story short, by sharing 7 moms' data, the data was the key to change. And it took 8 years, but that data connected NIH and CDC and HRSA and the Joint Commission and researchers, and it spawned CER. It got a registry funded where this rare disorder went from 0 in the United States. There was no evidence of the disorder even existing in the United States. It went from 0 to 128 in 2 years. So it became a public health issue with CDC. They started surveillance and protocols and have changed in the United States. And this disorder is now well known, and there are protocols to help prevent this. And so, just listening in the past 2 days, the power of data and the power of the patients and the patient organizations to create this data liquidity, to share this, to be the offerers, the contributors of data, I think really has the opportunity to change the paradigm in partnership with all of the other pieces to this network. So I see all of us, and I'm not leaving the CDRNs out at all, because I've read a lot of your proposals and how you've proposed to engage patients. And I think that overlaps is something that we really need to explore. How are we going to work together, and how we are going to interconnect all of our networks. So I want to talk about this power of partnership and patient engagement in research. I mean, I'm obviously very passionate about patient engagement in research. And now, not to separate it, but passionate about patient engagement in data network development. I mean, they're all packaged under research. But I want to change just some of the things that Bray spoke about yesterday. At PCORI, we have the privilege of visiting some of our researchers that we have funded. And we were recently in New Mexico with the Zuni Indian tribe, and they shared with us their image. And this is nothing against researchers, because I applaud you. But in the past, they referenced the researchers as mosquitoes, that they came into the Indian Zuni tribe, they did research, they sucked the blood out of them, and they left never to hear from them again. They didn't hear about the results. They didn't really know if they made an impact. And PCORI is really endeavoring to change that kind of image, because we want to create research in partnership with patients and caregivers and clinicians and nurses and all the stakeholders that really, at the sharp end, are really using that data, that information from our research to make hard decisions. So PCORI has launched, Joe talked about our board and the decision, the mission that they really created was really very courageous. And as a patient looking from the outside in, when I wasn't with PCORI, I read about PCORI and I said, no way. Is this organization for real? And when I joined PCORI, we had the opportunity to create PCORI together, and I applaud the board and our methodology committee. They even took a step further to say, if we're going to fund research of PCOR, patient-centered outcomes research, we are going to create a standard, a patient-centeredness standard, calling for the integration of patients in the entire research process, from creating a research question that's of priority to that community, to helping design the research, to decide if they're going to, what the comparators will be. And we have great examples. For example, we have a Latina group, Nueva Vida project, that it was the patients, the cancer survivors, that went to the researcher to ask to create this research together about breast cancer survivors and their caretakers. And so they created this research with the researchers. They picked the comparators. They chose the eligibility. They wanted to include all Latina breast cancer survivors, and not just those who had completed their treatment. So they were active throughout the whole process, and they've agreed to, when they're done, to disseminate to their communities at big national conferences, to be on the radio, to create stories in the way that their community will understand the results. We have examples of research that we have funded of, we've been talking about consent, that a community in Arkansas that reached out and they recrafted the consent form in a patient-friendly way that was understandable, that was familiar, that was not threatening. It wasn't just turning to page 5 and having somebody sign. It was really a patient-friendly, patient-centered consent form. So I think that's something we can explore amongst our task force. We've also we also have crafted our research around what we're saying meaningful engagement in research. Now, a lot of us know that people can write really well about being patient-centered and patient engagement, but does it really happen? And so I want to acknowledge Lorraine Johnson, who's in the room, who's on our Patient Engagement Advisory Panel. Our advisory panel and PCORI itself really push for meaningful engagement in research. Now, so when we get a lovely proposal and it shows the engagement, we've implemented practices within PCORI where we have engagement officers and an evaluation component that we evaluate the engagement in that project from when we fund it to the very end. And we want to learn what works in engagement. Do patients need to be engaged in the entire process, or is it more important at certain points? So we're committed not to saying you have to engage the patients, but we're committed to really learning what works and what levels are important. And we want to share that with the rest of the community. And so in doing this, we've created a framework that is showing the areas where we really want to see patient engagement, these areas we think are important, but how that's done is kind of like Devin was saying, one size doesn't fit all. We're creating this framework that shows the areas we want to see engagement, but we're compiling the best practices and the promising practice and the real life examples, isn't that what I think you're going to do, of what these practices look like. And so we think this framework is the framework of, we're not telling you, PCORI doesn't know the recipe. What we want to do is we're inviting the public to create the best practices. So it's a framework of innovation. So we've taken that kind of philosophy, and with our principles, PCORI has very strong, what we call PCOR principles, and they are trust, they are honesty, they are transparency, they are co-learning, we learn from each other, and they are relationships. And so we think we can transplant those principles, PCOR, patient-centered outcomes principles, into the patient engagement and data network development. So we envision, and as you wrote your proposal, you saw this. We want to see meaningful engagement, real engagement by your patients and your patient organizations in crafting, in assuring that they're absolutely involved in the governance of what's going on in PCORnet. We want to see that they're involved in the privacy issues and the ethical issues, that Devin brought up, the confidentiality issues. We want to see patients involved in maybe writing consents. We want to see patients involved in crafting how are patients going to be recruited and retained in this network. We want to grow this network. And so I'm getting a time card. I got actually 2 time cards because I'm not sure which one to pick. I'll take the longer one. Which time card do I have? Yeah. Oh, I saw another one. Okay. But this is, PCORI has reached out. We developed a framework also in our goals and our strategic plan that we want to really create a vibrant, thriving community of patients and others in partnership, then to engage them in research in a really meaningful way. Then when we do our research and we have our findings, that we disseminate it, we share it in a way that's understandable to the patient community in their language. Like when we had a roundtable with Latinas, they said, the way we learn is not through journals. It is not through, scientific areas. It's through our mothers, it's on the radio, and it's through storytelling. So we have to look at, when we disseminate our research, that we really think about how we disseminate that. And PCORI's committed to doing that. So to come full circle again, back to sending that Federal Express envelope in the mail, 15 years ago. And little did I know, or the other mothers, that would drive change. Going back to the opportunity that you have at your fingertips to really collaborate, to really create the model for the rest of the nation on how to share data, how to use this data, how to partner, and how to listen to the lessons that Bray shared yesterday. I'm hopeful. So that feeling when I sent that envelope was hope. It was opportunity, it was trust, it was partnership. So PCORI is eager to support you. The task force that Sean's going to talk about will provide you. We have hundreds of patient organizations at our fingertips. We have lessons learned from conducting our PCOR or having our researchers conduct PCOR. So we're on your side. We want to be with you in this partnership and in this journey. So I applaud all of you. I thank you. And, we issue an invitation and challenge at the same time, and we're all in this together. Thank you.
Great. Sue, thanks for that great overview. Next up is Sean.
Yeah, great. So I think I can pick up right where Sue left off, and I'm going to be talking today more about the sort of logistics and specifics of the patient leadership and or engagement task force, or I guess, was it Rachel Florence provided the name Inpatient Leadership Task Force? So we'll come up with something that'll stick. Maybe that'll be the first task for the task force. So I just wanted to mention that this task force will be sort of co-led by my CMTP colleague Pat Dverka, who is in the room today, and as well as support from Ellen Tambor and Jennifer L. Neighbor. We're also working very closely with a whole team of engagement folks from PCORI, and that includes Sue, Sarah Doherty, and I think everybody else is either named Sarah or Sarita, but I'm not sure. Or Sue. So I just pick randomly one of those names and hope it's close. And then we have volunteers for the task force from all but 3 of the networks. I'm not going to call out those 3, but you know who you are. And we're looking for a full complement of representatives. And as I understand it, the vice chair or there will be a co-lead drawn from the networks in about 3 months. And I don't know if this was talked about, but it looks like the process will be that the task forces themselves will select their the co-lead or the co-convener. So. And I think this was distributed in your welcome packets, but there's, for our task force as well as all the others, there's a charter and a set of deliverables and milestones that have been worked out for the patient engagement task force with the PCORI folks. Again, based on the input from yesterday, I have a feeling that an important first task will be for the task force to review the charter and the deliverables and the activities and the goals and just make sure that that now fully reflects the input from the community. I'm pretty sure they're not fixed in stone, but if they are, someone is going to take me to the woodshed afterwards. But just to sort of quote from the initial goal and purpose of the Patient Engagement Leadership Task Force, to ensure active and effective engagement of patients and consumers in the design and implementation of all components of PCORnet by serving as a technical resource for innovative problem solving, cross-project communication, and application of cutting-edge methods. So again, just let me sort of list off what I think are going to be some of the main, actual work of the task force. And first, I want to make sure folks know, you probably know this already, but the task forces are really, working groups. There's I think, Rich, you've emphasized that a lot of the actual work that's being done for the PCORnet is going to be done in the forum of the various task forces and cross-task force interactions. For this task force, we're certainly going to revisit the overall philosophy and conceptual framework and how we want to think about patient and consumer leadership and engagement to make sure, again, it reflects everybody's collective thinking, and then revisit the primary activities as well as the deliverables and the milestones to make sure it's compatible with that revised vision, which I think is going to be very important to kind of then guide the specific activities going forward. The primary emphasis of the task force will really be on identifying, refining, and/or creating new practical and implementable strategies for patient engagement. So, and I think, Mark, this is a point that you come up with, often emphasizing, which is, coming up with things that can really be done that are implementable. He used to say the same thing to me when we worked together at CMS, is try to find something you can actually do as opposed to something that would be nice to do in a parallel universe. So, implementable strategies to optimize, maximize patient engagement. And then, of course, as you've heard, frequently in this conversation, emphasizing that networks are, the intent here is not to impose any strategies or best practices on the networks, but make them available so they can be adapted as they are appropriate and modified, to fit the particular context. But hopefully, building off some standard and well-described approaches, taking advantage of tools and strategies that seem to be working well elsewhere, and applying those in each of the networks. So the task force will also be a forum for collective problem solving. It's my hope that individual networks will bring ideas, challenges that have been encountered in the context of patient consumer engagement, and kind of work those out together collectively. And then, maybe to emphasize a couple more, the task force will also be an important resource on patient and consumer engagement issues to the rest of PCORnet, the coordinating center, and as well as other task forces. So I think you've heard this, numerous times, again, over the past 2 days, that the work of the patient and consumer task force is going to have to inform the work of the governance and collaboration task force, the health systems interaction task force, informed consent, privacy, ethics, et cetera. I happen to think that this is the Uber task force, but that's just my opinion. But again, it struck me how much the solution to some of the what appear to be serious and almost intractable problems, including the sorts of things we heard today about IRB issues and informed consent, has got to be driven largely by the efforts and engagement of patients and consumers. And we don't get, if we're trying to achieve order of magnitude improvements in the speed and efficiency and patient-centeredness of research, which is something Rob Califf always reminds us is what we're trying to do, tweaking around the edges of the current framework isn't going to get us there, and sort of transformational change isn't going to come without the push primarily coming from the patients and consumers. Let's see, I haven't seen a sign telling me to stop, and if I do, I'm going to pick one of the table signs. Looks like I have 13 minutes left.
Yeah.
Okay. Anyway, just the last, oh, there it is.
There you go.
Okay. The last point I want to make is the sort of logistics. We do anticipate a reasonably heavy workload, particularly for the first 6 to 9 months, so just, you're forewarned. We are going to have an initial call, which you probably, the members of the task force already got a scheduling email to have an initial task force call that's going to focus on providing feedback on the evaluation strategy and instruments. So that'll be coming up in the next 2 weeks. We expect to have calls about twice monthly and hopefully to meet at least twice a year in person. So that's kind of hopefully a feeling for what we're actually going to do in the task force, and I'm very much looking forward to working with all of you.
Thanks very much, Sean. Bray?
Yeah, so I'm Bray Patrick Lake, and I'm the patient representative on the Executive Leadership Committee, at least for the next 10 minutes. So I'm thinking of this a little differently. I'm thinking that this should actually be called something subtle like the fire starting work group, because this is the group where we've got to make this change and we've got to make this shift. And Sharon Terry said so eloquently yesterday that we need to be the change we want to see. And I really want this to be the fast lane and the disruptor group, and not the people that are driving with the brake on that are afraid, to get over into the left lane and go fast. And so I'm not talking about running with scissors, which I do think is actually a skill on my resume that's listed out. Mm-hmm. But we need to go faster, and we need to think outside the box, and we need to really challenge the current framework. And I look at 18 months as a long time, not a short time. There's a lot of panic right now about, oh my gosh, what can we get done in 18 months? You can get done as much as you want to do. And I think Devin actually said this earlier about being a yes, our model and our mental model has to be yes. We need to find ways to do this. Those of you that were part of the coordinating center introductions earlier in the week know that I'm one of those crazy rock climbing people. And I'm also crazier than you know because I don't use ropes or harnesses. I'm a free climber. But I don't do that because I want to kill myself. I do that because there's a challenge to it, and we know that it is possible. We see people get to this level. But sometimes people have to make the first ascent, and it's highly calculated. It's not reckless. And I think that's what we need to do as a group. And so there are some legitimate aims and some activities of this task force and things we need to get done, which I think can be broken down into kind of 4 categories. And so one I would see is patient participation in the networks, as far as how do we come up with best practices for recruitment and retention, enrollment, and keeping the interest of the folks that are participating. What do you give back to them, and why is it meaningful? We need to focus on patient governance and legitimate influence, and I think there are best practices that are emerging. They might not be documented, but this group can share that, and we can figure out how we best do that. The tools and the models for patient engagement are evolving, but again, they have to be shared. And I think this group, we can really take the opportunity to share a lot of our knowledge and lift up the curtain and say, this is what we do at my organization. Let me share it with you. And then it needs to get outside PCORI as well. And I think after this, it will. And a huge part of this group, I think, will be working on the communications and messaging. For those of you that were new in this room sitting here going, I've never been to a meeting like this, they're speaking in all acronyms. How am I going to go back and explain this to my patient constituencies? I think this group has a real opportunity to come together and think about some of those things. But I really want to set the tone now that it's not enough to do. If you do what you do, you get what you always got. And we're not going to do that. I think we need to set the tone and say this is going to be different. Jeff said also, if you're going to a meeting with a lawyer, take a lawyer. Well, this time, how about you take a patient and let's sit down with some of these IRB issues and let's really say, this doesn't best serve this. You created this policy, it's taking forever, lives are being lost, we're tired of it. And put them in the room and make them face us. So I really want this group to be the fire-starting group where we come together. We've got the support of people that have a methodology and have tools and have the science, but you guys need to bring your passion and your ideas and help us really channel that into something that's going to truly make a difference.
All right, thanks very much, Bray. I would like to open this up now to comments and questions from those of you who are here. Mark, do you want to start? Grab a microphone.
Well, one of the benefits of this whole conference has been to get to know our patient leader, one of our patient leaders, a lot better, who's here with me, Debbie McCall. And we were chatting over breakfast, and two things relevant to this discussion came up. One is a limitation of our current process, and the other potentially an opportunity. The limitation is that I would like to, we're sort of opening up the call for joining task forces to our patient leaders, and she's really interested in two of the task forces that I'm also really interested in being on, governance and ethics. And I think our current rule is only one from each PPRN. So I don't know if there's a way around that, but I just want to point it out as a limitation currently. The opportunity is that we at UCSF have sort of a well-established clinical research training program, and we have a flagship course, Designing Clinical Research, which I think actually might be really exciting to have patients actually enroll in that course and give the opportunity to do that, maybe with a partnership with a researcher at their institution. And the course is all about designing a particular research protocol and idea. And Debbie was excited about that possibility, and I think we could potentially open that up to the network.
Any thoughts? Several of you have mentioned resources that you have available that could help patients lead more in developing these.
I'd like to comment on that. PCORI is really committed to. We understand that we're creating new territory, patient engagement in this area, and that there's a call for capacity building. There's a call for tools. There's a call for resources. And Bray and I were just talking about connecting some of the tools that have been created. PCORI right now is we're just completing a curriculum on PCOR, on what does it look like, this relationship between researchers and patients, and how do they work together, and what are the cultural differences. And Bray was talking about our curriculum that her group is working on clinical trials, and then Lorraine's in the group, and Q has created a curriculum on evidence-based medicine, and you have information. So I think that's something that as a task force we could really look at. How do we bring all these tools together and share them and get the right language in there so we can bring in others. So I'm glad you brought that up because I didn't say it in my presentation, but that's something that PCORI is absolutely committed to, is capacity building.
And I just wanted to be sure I was clear in terms of the course at UCSF. Was your notion that it would be useful for the patient community to kind of get that education and training, or was that in part that their presence in the course would bring something to the to the learning environment that perhaps was missing, in the existing content of the course? I'm just wondering, were you thinking of a bidirectional kind of sharing of?
Well, frankly, I was thinking of it not bidirectionally, but it's a great idea for us to consider that.
Thanks, Terry.
Thank you. This couple of days has helped to illuminate for me the larger cultural change that is underway. And when I listen to Bray's comments, it makes a lot of sense to me because I'm not a clinical researcher. But what I'm wondering is how the clinical researchers are hearing this. And my concern in the midst of a cultural change would be for the clinical researchers not to have a voice to express a reaction there, but rather hunker down and say, this too shall pass, and we'll go back to our business as usual. because I think there is a two-way street. And so I just wanted to be sensitive that we all need to be accepting the task of cultural change and having an honest two-way dialogue where people feel safe to share their points of view.
That's a great point, Terry. And what hopefully this meeting and the other early activities of the network are going to do is establish that safe space for driving real culture change. Culture change is not easy, but I have to say, from a lot of the clinical researchers here in the room, I think there is a pretty strong commitment to make those changes. That doesn't mean it's going to be easy. It doesn't mean it's not going to require a lot more hard work together, but it's a great point to bring up, and hopefully one that we can come back to.
I think it also kind of emphasizes that it'll be important on the patient engagement task force to have a token clinical researcher there.
Good point. I'm going to go to Beth and then back to you.
Hi, Beth McGlynn from the Kaiser Permanente and Strategic Partners Portal Network. I have a sort of two-part, and I think it's somewhat related question, and it reflects a challenge that we encountered when we were working on the proposal. It's very easy for me to imagine, and we did, I think, a reasonably good job engaging patients with rare diseases and patients with life-threatening illnesses. So colorectal cancer is our common condition. We didn't do so well in the obesity realm. And so I guess the question to you, and I think this is probably on the list of asking for help from the task force, is how we can engage that population. We did have conversations with one of the patient groups that we're working with, Smart Patients, and they basically said, we'll work with you on colorectal cancer and we'll work with you on adolescents and adults with congenital heart disease, but obesity we don't think fits the model of how we've engaged with patients to date. So I think in some ways, understanding how we can learn from others about best practices and engaging that community would be very welcome. And we had also hoped, and this is a question we put out, that people may have engaged some advocacy communities more successfully. We were unable, even though as a system we work with those communities in bringing the ones that we've worked with to the table for this. So that's just sort of an ask for help. But also I think a recognition, and this kind of leads into my second question, that community may be different. And what engages them may be different, and we need to be sensitive to that. So this is a little bit of our theme of not one size fits all, but we really haven't talked about that group, or given I think the focus on rare disease. The related question has to do with heterogeneity. So one of the things that we're working on as a system a lot is the fact that people, and there was some reference to this, Sue, in your opening remarks, want to get their information in different ways. And frankly, it's not all about the labels that are easy, race, ethnicity, education. What we're learning in a lot of the work that we're doing as a system is that people have preferences, and they want to tell us those preferences once as a system, and then they want to have us communicate with them, whether it's in a clinical manner, in a business manner, in a marketing manner, all in a education manner. They want to tell us once what those preferences are, and they want us to remember them and use them in all the ways that we touch them. And so I think one of the things that we've been struggling with, and again, that we would like to hear from people about, is it's all well and good to form these governance committees that have 2 to 4 to 6 representatives on them. It's daunting for that to represent the heterogeneity of patient perspective. So we have some other mechanisms that allow us to reach more like hundreds and thousands of patients. But I also want to think a little bit about how we build that respect for and awareness of and ability to integrate that heterogeneity into the work we do, and not get too locked into finding a solution that works for the 2 people that we're talking to most often, but doesn't work for some large portion of the patients who share that diagnosis or that condition or that concern. So I think that may be more of a speech than I meant, but just those are the issues that have been keeping us up at night, and that we look to this task force for some help with.
All right, Beth made some great comments based on some extensive experience with trying to involve patients in some important and I think challenging areas of research. Now, we don't have time right now. I would like to try to get in maybe one more comment to this session, but if you all could talk maybe broadly about how important issues like these can be addressed as part of the task force structure and the work of PCORnet, maybe briefly, that would be great, and we're going to obviously come back to these. Thanks, Beth.
Well, I'll address kind of the overall how to outreach to patient organizations and something regarding obesity and other areas. PCORI has had several working groups with a variety of patient organizations where we've made lots of contact with obesity and other areas that you're interested in. Another thing is that we're going to be releasing a funding announcement about obesity, so we'll be working very closely in matchmaking between patient organizations and researchers. And broadly, though, we are also looking at, we're mining our data right now to look at what have we funded in areas that you are interested in, or what you're, especially the PPRNs. For example, we have funded research in sleep apnea. We have funded research in other areas that your PPRNs are focusing on. So we want to start connecting the dots. So we've got the resources and the connections at PCORI that we'd really like to share with you in any way that we can.
Okay, I'd like to get in maybe one, two, maybe if we can do these quickly, and then maybe a final comment from you all at the end. Please go ahead.
Okay. Two quick comments. The first is that people develop, grow, and become ill in the context of their family. You acquire your health early, you maintain it in middle age, and it declines as we get older. So when we talk about patient engagement, we're leaving out a number of really important stakeholders, and that are the caregivers and parents and family members. And it's not just a pediatrics issue. Yes, I am a pediatrician. Full disclosure, it's a life course issue. So as you begin to elaborate your agenda in the engagement task force, I'd encourage you to have a life course perspective, because the word patient actually excludes many people who are affected by illness just as much as the individual themselves. The second is an area that I'm confused about, and that is brand conflation or potential brand conflation. How we explain PCORnet to individual patients who are within a care center, within an institution, within PedsNet, within PCORnet. So one of the challenges that we're going to have in terms of telling the story of PCORnet is how to distinguish a unique brand. And that really confuses me. And I think that's something for the engagement task force to take up.
Thank you. Great comments. And go here, and then Michelle.
Thanks. Michael Sade at Cincinnati Children's Hospital with the Improved Care Now, PPRN, and the National Pediatric Learning Health System, CDRN. And I really like your comments about engagement. And I'm thinking about, this in the context of the learning health system. If PCORnet is to be either a learning health system or a system of learning health systems, three questions arise, and they have to do with engagement. One is, who's learning? And we argue that, we could have a small set of experts learning, or we can have everybody learning. And what would engagement in a learning health system mean? Part of being part of the production of information, knowledge, and know-how at every level. Learning about what? There are probably hundreds of topics that are within the bailiwick of research, but if you actually have a channel for patients and parents and caregivers to generate topics, I'm certain you'll get a much broader variety of topics. And then learning how, beyond the traditional paradigms of learning, how are people making sense of their condition in their homes, in the context of their lives? You mentioned stories and other ways of understanding. So I just wanted to raise those three ways of trying to frame an approach for engagement in this learning health system.
Thank you very much, Michelle. Button.
Is this on now? I love Bray's slide yesterday. It's almost like a Maslow's hierarchy of patient activation. And when we're thinking about obesity and how to reach those patients, I think one of the things we're missing here in trying to reach a more diverse set of patients is that patient activation occurs when you have certain hopes and expectations, and those aren't met by the healthcare system and the medical product options available. And many of our more diverse patients don't even have those expectations or hopes to be dashed. So as you are trying to expand this impact, think about how you touch those patients in that way. I know a lot of the heart groups like Women Heart, American Heart Association, the diabetes groups like American Diabetes Association have patients who struggle with obesity, but have had hopes dashed in other settings. So there might be a way to get at those patients and reach them through your efforts, if obliquely and not so much directly.
Those are great comments. All right, since you all were so efficient, one more right over there.
So two things really jumped out at me. My name's Adam from the Sleep Apnea Network. I think it was Einstein who said the definition of insanity is doing the same thing over, expecting a different result. I'm sure you scientists could back me up in that. The status quo doesn't work. That's why we're here. That's why we're gathered together. So with that being said, we have two jobs. One is to communicate to the healthcare providers, the healthcare networks, how to get patients to enroll in this, and or their spouses and or caregivers, which was a good point somebody just made a little bit earlier, but also to get the outside public, the everyday people that aren't in the healthcare system, to take part in their care and what's in their best interest and to get the answers they're looking for. With that being said, this really comes back down to a communications sort of plan for PCORnet. And I don't know exactly what's going on with the video and the interviews and stuff like that, but this creation of this network, this meeting, these task force, it needs to be documented. People need to see the conversations we're having. This can't be behind closed doors. And, we'll come up with the answers, but the burden to get into this has got to be easy. People are putting their information out there on Facebook, on Twitter. They're willing to give their data. If they trust the patients that are in this room talking with the researchers, the scientists, and all the other medical professionals, as long as we have a stake in the game and they know that we have their best interests at hand, they're going to let us use their data and actually make use of it. So not just collect the data, but actually give us something back for it. I don't know if anybody's been to Disney World lately, but if you had the chance, it's an amazing experience. You go there, you get a bracelet with a radio frequency. It's got your hotel room. It's got your tickets. It's got, where your child is. If they get lost, they can find her. If it's your child's birthday, they'll bring the special character right to you. They're using that big data and accumulating it all at the same time, but actually making it work. And that's my envision for what PCORnet can be, and hopefully it will be. But we got to get through all the bureaucracy and the minutia of getting there. It's a real-time world, This event's being tweeted out real time, so you don't have a chance to group and huddle up and respond to it. You're gonna have to move quick on our feet.
Thanks very much for that comment to end on. I want to thank everybody for their contributions to this really critical discussion. And it's not just about discussion, it is about actionable next steps. Any quick final comments from all of you? This is going to be an ongoing process, but one that's, as Bray said, needs to be very much oriented towards action now.
Yeah. So I just say, once again, the conversation just highlights what an extraordinarily rich and thoughtful group this is, which is, really exciting about this, probably the most exciting thing. And the second thing is, I think I would endorse Bray's framing of, the Light of Fire Task Force or something like that. So, Firestarter.
Yes.
Yeah. So I think we might not have that as our formal task force name, but we'll adopt that as the spirit of the task force.
Just a comment about the word trust, Adam. And we've been talking about it all morning, and we need to develop a network that is trustworthy and understandable and familiar to the patient population. And PCORI's whole premise is that we believe that by engaging patients and others throughout the entire system of creating this network, through creating our research, that ultimately that network will get used and our research will be used because we've embedded the patients throughout the entire process. And we think that will create trust. We think this. And so thank you for bringing up the word trust, because I think ultimately when we talked about a vision, I envision a network that is trusted and used and vibrant and understandable. And that's just something that I hope that we can just keep our eyes focused on that.
So for the PPRNs tomorrow, we are going to focus on communications and messaging and what you need if you come to a breakout session. So I want you to know that there is thought being given to that, and we'll take your input. But for everyone, I want you to think about the team from Apple that built Macintosh or built iPod, and then walking down now into your kitchen and seeing 11 of those products charging your household. I really want us to focus on being the Mac team. Like what we are doing now, I promise, is going to create change, but we have to decide that it is the culture change that we're shooting for. And I think there's a huge opportunity through our collective voice and engagement.
Great. Thank you all very much for a terrific discussion. Even the Mac team needs lunch, so the next thing up for this group is lunch. I have a couple of announcements just to orient you to the rest of the afternoon together. So lunch is going to be served in the hallway next to this room. In Zilka. Okay, so and do people eat? Okay, so that's where you go for lunch, and then do we come back here? Or? Okay, so get the lunch next door. Bring it back to your table. We did have a little bit of rain here at the front of the room. That seems to have subsided, so all good on that standpoint, I hope. If you could be back here before 1 o'clock, that would be great. It takes a little bit of time to get the plate, bring it back here, and also please try to factor that in. We're going to have a working lunch where we will hear about the evaluation plans for the network. This is really important to help make sure that things do stay focused on what's important and not just checking a bunch of boxes. So we need your input and engagement in that too. And then most importantly, the last session of this afternoon is really your session. It's titled about the next steps for the network, next steps for developing core research capacities. But this is really going to be about input from all of you. It's going to be your session, not a bunch of people talking up here, though we will have some reactions and opportunities for comment from Joe and Rich and Rob and some of the others involved in the coordinating center. You'll find when you get back to your table some index cards on the table. What we'd like you to do, maybe if you have a few minutes over lunch, and then we're going to give you some time at the beginning of this last session to come up with what you would really like to make sure gets on the table for issues and for how to act on those issues that have not fully been recognized yet. So specifically, and I'll remind you about this again when we start the session this afternoon, what's the one thing you haven't heard yet during our sessions that is very important for this group to be considering? And if you've heard it, but you haven't heard enough about it, that'd be a good alternative to put for that one thing. So this is discuss with your table, people who have some different perspectives and backgrounds that you do, and come up with one. And then next, what are the two most important next steps? The two most important next steps that PCORnet and your organization need to take to get action moving forward towards the goals of PCORnet, okay? So one thing you haven't heard about or haven't heard enough about, two most critical next steps. So we'll have some time to discuss that, and then you all are going to present that, and that's going to be the main wrap-up for this event and the next steps forward. All right, so right now, let's break for lunch and hopefully be back here by 1 o'clock. Thank you very much.